It's 12:30.
All right.
We
Good
are ready to go.
afternoon. We are now recording, and this is CMDA Monthly Journal Club. And I am going to let Singh Pallet do a quick introduction and a quick presentation before we get started.
Hi, everyone. Singh Pallet with CMDA. We're so glad that you're here for Journal Club. Before we get started on the journals, just wanted to make a quick announcement, one that the CMDA annual conference is coming up April 25. So be sure to sign up so you can join the in-person annual conference here in Denver. We're going to start off today with Dr. Sarguni Singh, who's going to tell us about some work that he's doing at the University of Colorado. It's very exciting, and it might be coming to a nursing home near you.
Thank you, Singh. Hi, everyone. My name is Sarguni Singh. I'm a hospitalist. I primarily work on our inpatient oncology service at the University of Colorado Hospital. And we are studying a palliative care intervention called ALIGN. It stands for Assessing and Listening to Individual Goals and Needs. And we are pairing older adults with advanced cancer who are being discharged to SNF for rehab with a palliative care social worker who will follow along and conduct virtual visits with patients during their nursing facility stay, approximately every 1 to 2 weeks, depending on their needs, and then follow these patients for up to 45 days after discharge from the facility when they transition home to long-term care. Our hope is that we fill some palliative care gaps for these patients because they're at high risk for readmission, poorly controlled symptoms, and so the ask really is just that these social workers will be communicating with your frontline care managers, social workers at your facilities to try to get onto these patients' schedule for a virtual visit. The intervention is free of cost. So we just wanted to let you know that there might be some outreach from our social workers conducting the intervention. And happy to put my email in the chat if you have any questions. Thanks again.
Very important. Thank you, Dr. Singh. It sounds like the patients will be signed up from the hospital as they're discharging. There's no need to sign them up at the SNF.
Yeah, really, we want this to minimally disrupt any SNF workflows. So all of the recruitment and data collection will happen in the hospital. And we just need some help conducting the virtual visits in terms of getting on their schedule during their facility and maybe helping set up with the Teams visit, which we train them on in the hospital as well. So we really hope that we don't disrupt any workflows. We did a pilot study of this during COVID and received overwhelmingly positive feedback from staff. So we're hoping to study it in a randomized trial this iteration.
Great. Thank you for the introduction, Singh and Dr. Singh. I'm going to turn it over to Dr. Gahm, and we will make some of the documents available after the meeting. And if you need others, you can reach out to us.
Yeah, and even after telling you that we could distribute the gold guidelines, as I open this, the thing that blinks on and off is copyright material. Do not copy or distribute, is what this says. So it's very interesting that you download this for free, and I'm going to tell you how to do that in a minute, but we can't really distribute it. So welcome, everybody. We are going to do a whole bunch in a short period of time today. And the first part of this is going to be focused on COPD. And from there, we're going to jump to new drugs that I think you might see or at least might want to know about going forward. So like always, I talk a lot. If you have questions, don't worry about putting them in the chat. Just come off of mute and just interrupt me, and let's deal with them as they pop up. First thing I want to do, and I don't know if everybody's aware of this or not, but if you're not, you should be. There's a group called, they create this thing called the GOLD Guidelines, and here it is on the screen.
Okay. So do we think that she needs both of these medications, or could we get rid of the duloxetine?
Jen, just get rid of the duloxetine.
I'll try to mute.
I'm just kidding. So GOLD Initiative, the Global Initiative for Chronic Obstructive Lung Disease. This has been going on for more than a decade. I'd have to look back, early 2010s, I think, maybe even longer. They're a group out of Atlanta, and every year they put together just the most comprehensive overview of what you should do with chronic obstructive lung disease. They update it every year based on new information. It does have this little thing that says don't copy or distribute, but if you just Google GOLD guidelines, this pops up and you can download it. So I'm not sure I understand why. I guess they want to keep track of individually who downloads it, who doesn't. The one that I have here is actually, it's 42 pages. You can see down here. This is the pocket guide. So this is supposed to be the quick reference. The full guide is only about 30% larger, so you can download the entire thing if you want to. But it is really a great resource. This is something that if you have a computer, download it, keep it for a reference. It's as good as it gets with COPD. All right, so that's the very first thing. Now we're going to talk about real quickly a number of things having to do with COPD. But the first one, I've got 3 or 4 articles that are all going to say the same thing. And we're going to go through them all just because it is so hard to convince people. You went through training, you did this, you kind of trust your mentors and your training, and you forget that. I mean, one of the things, Bob Schreier was our dean and head of our medical program. And one of the things he told us when we graduated from medical school is he said, you know, the most important thing going forward is to remember that at least 50% of what we taught you here in this very wonderful medical school will be outdated and wrong within 10 years. And 70% will be outdated and wrong within 20 years. He said, so, you know, you got the basics, but learn how to learn. Don't just remember this information. And he's right. So here we are. This is really the next few slides are going to talk about steroids. Okay, so if you read the GOLD guidelines, one of the things you'll find out, I'm not going to talk about oral steroids other than for acute exacerbations. They're real prescriptive. It's for adults, 40 milligrams a day for 5 days, stop. It's none of the 2-week taper or, well, 60 is a little better than 40 or 20 is enough. They just make it really simple. It's 40 milligrams a day for 5 days, not 7, not 2 weeks, not 10, 5 days. And the data is real clear that that's as effective as anything else. It works better than other choices. Do it. So that's really oral. And beyond that, oral steroids not indicated. Chronic steroids, oral, parenteral, not indicated for COPD. And people will tell you individual stories and so forth, and we're going to touch on one of those. But the truth is that if you look at this in blinded fashion, they don't work and they cause problems. All right, so that's all we're going to say about oral. Now we're going to look at inhaled steroids, and I've got a bunch of stuff here. The GOLD guidelines, I'll give you the bottom line first. Bottom line is don't use inhaled steroids. Now, if you have somebody with concomitant lifetime asthma, or they've got reactive airway disease after an upper respiratory tract infection, you know, or if you do an eosinophil count and it's greater than 300, well, inhaled steroids might have a place. But if you don't meet those criteria, which is going to be 99.7% give or take of our population, don't use inhaled steroids. That's the bottom line up front. That's what the GOLD guidelines say, if you go through and read them. And then here's some of the data. So inhaled steroids linked to fracture risk. So this particular study in the references down here at the bottom out of the British Pulmonary Medicine, use of inhaled corticosteroids associated with a 19% increase in fracture risk when compared to treatment of COPD without inhaled steroids. And then the rest of this is just the details of that. But, you know, even though they're just inhaled steroids, some of that gets absorbed. And over time, There's increased fracture risk. Okay, well, that's one good reason not to use them. Here's a study out of one of the JAMA Internal Medicine. It looked at pneumonia hospitalizations among new users of combination inhalers. Patients that entered this had to have a diagnosis of COPD and fill a combination inhaler with a LAMA-LABA combination or an inhaled corticosteroid and LABA combination. And this was over a 5-year period from 6 years, January 2014 through December 2019. You had to be over age 40, and if you had a prior diagnosis of asthma, you were excluded. Primary outcome they looked at was the first moderate or severe COPD exacerbation and pneumonia hospitalization. They started out with huge number, 138,000 patients, and from that they came up with just over 30,000 matched pairs. So 30,000 people on the corticosteroid LABA and 30,000 on the LAMA-LABA. And the folks on the LAMA-LABA had an 8% reduction compared to the others in their first COPD exacerbation and a 20% reduction in pneumonia. So again, the LAMA-LABA, much more effective. So that's the second piece of evidence. Number 4, let me go. Here we go. This is just a summary of patients. Again, it's really an article about is triple drug. So a lot of the LAMA-LABA inhaled corticosteroid. And the question is that just like one too many? And so it's another study. This was a German study. And what they looked at was the time to COPD exacerbation that got somebody hospitalized on the triple versus a double without the corticosteroid. And it also looked at some adverse effects. It took about 14 months for half the people. 14 months for half those who made the switch to develop a new COPD exacerbation, compared with only 9 months. So if you went from a triple to double without the inhaled corticosteroid, it's about 14 months on average until you were hospitalized for COPD, versus if you stayed on the triple, it was only 9 months. So they did worse. Okay, one more study. Okay, that's number 4. Now number 5. And so this gets to one of my pet peeves, which is sort of like the aspirin for primary prevention stuff. Lots of data, wonderful data, lots of experts, lots of recommendations. And here we are 7 years later, and people are still giving low-dose aspirin for primary prevention of heart disease. It doesn't work. It causes more deaths than it prevents by a lot, but people still do it because they're used to it. And I think this is the same thing. We're so used to inhaled corticosteroids, there's almost no amount of information that will convince people to switch. So I'm going to keep harping on it. Here's a couple more studies. This really, the bottom line here shows the effects to try to de-escalate and get people off. And you'll see, 20 at the bottom there, 26 of 45 people they tried this on didn't complete going from triple therapy to double therapy because they just weren't compliant. They're just convinced triple works better despite all this evidence that it doesn't. Let me see. Oh, okay, so that's really all I have to say about that. If you're one of those people that's still using inhaled corticosteroids, I would just encourage you to read the GOLD guidelines, read the data, and decide they don't work and get rid of it. Take the plunge.
Greg, does it matter if the person may have a concurrent diagnosis of asthma, or we think they have it?
Yeah, and that is different. So again, with all these studies, they left out the people with the concurrent asthma diagnosis. It would be, except after a viral respiratory infection, it would be really unusual to develop asthma as a kind of like schizophrenia as an older adult. So people with asthma have had asthma for a while. They know it. And those people, yeah, it is different. Inhaled steroids, one of the cornerstones of care. So you got to do that. The last one I was going to show you, I'm going to pull it up here. This is kind of cool. I don't know where this is going to go. I haven't seen it yet, but for the first time in a very long time, there's actually a new inhaler that is available. This report is from months ago, so I don't know, if anybody's even seen this drug. Jen, you're on the call. I don't know if you've seen this or if it's being distributed yet, but unlike a LAMA, LABA, or inhaled corticosteroid, this is an inhaled, and it's called ensifentrine, or, I mean, you would think they'd give it a name people could remember. Ohtuvayre, I can't even pronounce it. But at any rate, it's an inhaled phosphodiesterase 3 and 4 inhibitor. It's nebulized, acts as a bronchodilator and a non-steroidal anti-inflammatory. And it was improved through these 2 different studies at COPD. It improved lung function and reduced exacerbation rates. And the biggest problem I had with this is, again, it was compared to placebo. What I'd love to see is, well, how does it compare to llamas and labas? I mean, so when this comes out, will I want to use it? I don't know, because I don't know how it compares to the drugs we're already using. And then the side effects, primarily, I don't know, back pain, hypertension, UTI, everything is UTI, diarrhea, but they were pretty rare, less than 2%. It's not a rescue medication, which makes sense as a PDE inhibitor, but nonetheless, you may see this in the future because there are providers out there that just think everything that's new is better and they're going to use it. So you may end up at some point in time admitting somebody on this drug. All right, and that's everything I had to say about COPD. Any questions on any of that before we go on?
Greg, I have a question.
Yeah,
here.
Lee.
We see a lot of people getting long-acting beta agonist drugs as well as short-acting beta agonist drugs. And so what are your thoughts about that combination? I mean, years ago, they talked about the downregulation of beta receptors for people receiving the short-acting drugs, which would often get abused and overused. So
yeah, I would say I don't let people do that in my facilities. I'm much more restrictive probably than anybody else on this call. But yeah, the use of both is really contraindicated. You're just overdosing them with beta agonist, which isn't going to help their lungs more already, but it is going to lead to tachycardia, maybe arrhythmias, anxiety, other issues. Yeah, it's just not necessary. Same thing if you're using Spiriva at the same time you're using a Atrovent and nebs or something. You can double dose on both of them, and it's not necessary, and at least in my mind would be contraindicated. Nice to hear you, Lee. I haven't talked to you for forever.
yeah, it's been a month or two.
Yeah, no kidding. Okay, so from there we're going to go to this one's just for fun. If I can find all these things, here we go. This is my favorite, so I put it first. This has the potential to be a game changer. This just came out probably in the last 2 months. So here's a new drug, suzetagrine. And I know Leslie talked about pain yesterday, and we talked about this right before the meeting. Jernavix, again, I don't know how they get these names, but this is a non-opiate peripheral acute, moderate to severe acute pain medication. You can read through this while I'm talking. It's fine. Bottom line, they looked at quite a few folks with a couple weird acute pain presentations, but they had three groups. They used an opiate, they used this drug, and they used placebo. And the bottom line, both the opiate and the placebo, opiate and this drug were better than the placebo at addressing pain. And those two, couldn't tell them apart. They were about equally effective. So that part was good. The nice thing, it only acts peripherally. There's no addictive potential. So, there is possibility for this or other drugs that come along just like it to just take over the market, except for people that are already truly addicted. Now, the downside, I did hear rumors that it is, when it is distributed, when it's available, it is going to be probably prohibitively expensive. Again, you made the drug, why not charge a lot for it? I don't know. That could be a downside, but nonetheless, it's something to keep your eyes open for because it could be a really wonderful thing. All right, nothing else to say on that one. Next, let me see if I can find number 2. Okay, here you go. Oh, here it is. Sorry, I have to jump around. This is we're going to see more and more of this in the coming couple of years, I would think, looking at factor 11 inhibition instead of a DOAC, which is a factor 10. There are several new drugs. This was one of them. Ebalism, it's another IMAB, and hopefully they'll come up with a name we can remember. Nonetheless, this drug works at a different place on the coagulation cascade. In the comparative trials, it was equally effective to Eliquis, which is, of course, if we look back, Eliquis is better than Xarelto, which we don't use anymore because of it's on the Beers list. Both of them are better than warfarin. Both of them are better than low molecular weight heparin, so we should be using it, with some exceptions like valvular heart disease, we should be using Eliquis. This was as effective as an anticoagulant as Eliquis and much safer, a lot less bleeding risk. My own guess is within 2 to 3 years, it will do to Eliquis what Eliquis did to warfarin. It'll just supplant it. So these are coming, and I know there are 2 or 3 of them being looked at, different companies. But be on the lookout for them. And this is one of those, I know a lot, when the DOACs first came out, and Pradaxa about the same time, there was a lot of hesitation to move from warfarin to one of those because it was new and there are going to be problems. But if you read the data for hip fractures, comparing it to low molecular weight heparin, or for atrial fib, looking at the others, the data was thousands of patients, and it was excellent. And this is the same sort of thing. So I think we're going to move there. Anyway, they're coming. Next on the list, okay, let's see. Oh, this one I think probably everybody's heard about because weight loss is such a big deal. But oh no, sorry, must have hit the wrong button there. This is different. This is the sleep apnea drug, tirzepatide, approved for obstructive sleep apnea. I think people are already using this for other stuff, but it's interesting that now it at least has an indication. The upside is it works. The downside is you got to keep using it forever. Even if bottom line, you've lost the weight, the obstructive sleep apnea gets better, you can't stop it. Now, my guess is that this is a highly lucrative field. There are lots of research going on to find things that will either last longer or will keep working or easier to take than injections. But at any rate, at least there's now a drug approved for obstructive sleep apnea.
Greg, have you heard facilities having troubles administering a GLP-1? I guess there's some facilities that are very concerned about the cost and also about diversion from staff.
Yeah, it is a problem. I mean, it's almost like using, some of the liquid, liquid morphine. I've been in several buildings where we've caught or found people putting saline in the bottle and taking the Roxanol out. And yeah, I mean, that's always a concern. And I think that as expensive as it is and as popular as it is, we may see a change soon where you treat it like you do opiates. It takes two sets of eyes to open it, to move it. And, maybe there'll be some friends and get away with it, but maybe it'll help. Yeah, I have heard of it. I don't know. I don't know what we do to deal with it. And I do know they're trying to negotiate it. At least the previous presidential administration was trying to negotiate this year to get Wegovy and Ozempic more affordable. I don't know where that's going to go now, but I know typically the negotiated price that Medicare's gotten is still about twice what you would pay in Europe, even though it started out at 8 to 10 times. So I don't know. I mean, it may get more affordable. Nonetheless, in the right patients, I think it's realistic. Let's see. This is another one, a new extended release Parkinson's drug. I don't think any of us are going to choose this or choose to prescribe this, but here it is. It's Crexont. It should be available. Parkinson's, I can tell you from personal experience dealing with family member with it, it's just so hard. Good days, bad days, up, down. Every neurologist wants to give short acting 5 or 6 times a day and long acting at a different time 2 or 3 times a day and add other drug. It gets so complicated. I don't know how anybody does this. So at any rate, here's one more entrant into the field that you may see. I asked Leah Watson about this and when this came out, and she hadn't seen it, heard of it, used it. So if she doesn't know, this is really new. I don't know where we're going to go with it. It's a brand new drug, works for schizophrenia, that works differently than all of the drugs we currently have available. Cobenfy, and it targets cholinergic receptors as opposed to dopamine receptors. It apparently works. The studies that got it approved showed that, again, it was as efficacious as the drugs we do now. I don't know. I mean, if there are fewer side effects, I'm waiting till Leah and other psychiatrists get a little experience with it before I want to go this direction. But don't be surprised, again, the people that want to try have had so much trouble with everything they've tried with antipsychotics. People, if it's available, there will be people that just jump to this. So Cobenfy.
Hey, Greg, Lee Annenberg again.
Yeah, Lee.
I've been checking all the prices of all these new drugs you've discussed, and every single one of them, and in Hippocrates, say there's no information available. And my history of doing that usually means it's in the thousands of dollars, So, but there's no guidance about the cost of these drugs. So
yeah, and I think part of it, Lee, is they wait until it gets out and there's pressure for Medicare to pay for it. And once Medicare pays for it, then all the other Medicare Advantage plans, everybody has to cover it and pay for it, and then they figure out how much they're going to charge for it. I don't know. I mean, I'm glad I'm not in that business. You want to make it expensive enough that you make some money on it, but not so expensive that nobody buys it. I don't know what the answer is there. Yeah, I don't think, and a lot of these are new enough that I don't think maybe they haven't even figured out. Maybe they're doing the studies now in small areas to find out, that supply and demand curve, where we can make the most profit. So.
The question in the chat box,
Go ahead.
I think it's about Cobenfy. Does it have cholinergic side effects?
Yeah, they all have side effects, and I'm sure that it does. I don't know the studies that came out that announced it and showed this, didn't really dig into that very deep. I can try to figure that out, look it up, but I would imagine it has to.
Yeah, I'll jump in and say hello. And I was on a committee that reviewed this one nationally, and the trospium's there as an antidote. So otherwise, we'd all be drooling and peeing, and it's a totally, you want the cholinergic activity in the brain, which does good, and then you block it peripherally with the trospium. So the trospium's there simply as an antidote to reduce the side effects of the cholinergic activity. So
That's great.
it's interesting.
So my question for you, Jeff, how come you retired? You got all this great information.
I pointed out to Sing I'm semi-retired. I'm still doing some work down now in Pagosa Springs. So hello to everybody, and I'm going to try and not become obsolete just yet.
That's great. I love it. Thank you, Jeff.
Thanks.
So here's another MAB, for treating cancer cachexia. And again, not one we're going to order, but you may see it. Because nobody likes to see weight loss, and here's a way maybe that you can treat weight loss without increasing morbidity and mortality. I'm going to hurry through some of these. Let's see what's left. Oh, this one I think you guys probably have heard about, the once daily, Victoza approved generic version. So maybe it gets cheaper, maybe it doesn't. And I think that's it. Okay, 1 o'clock. We just hit it. Questions or anything else?
Thanks, Greg. That was fantastic.
All right, quit using inhaled steroids, watch for the new drugs, and have a great day.